Okay, we're now out of MOA territory. If you made it this far, you know what? Good for you. Good for me too for making it this far because like I'm recording this at like 1:50 again. Why am I doing this so late at night? Why are you watching this so late at night? Probably the exam. So you know what? Hats off to you for putting up with this. Okay, indication. So you will see the indications. It's a lot more extensive compared to the first gen. So again, schizophrenia only effective for positive symptoms. Unfortunately, there are less than no secondary negative symptoms, but again inefficacious for primary negative symptoms. Again, this primary negative symptoms, those are from the schizophrenia itself due to dysfunctioning of dopamine release in the mesocortical pathway, right? So this is only efficacious for secondary, not primary. And again, because of the various receptors that it binds to, it also has efficacy in mood disorders. So bipolar mania and bipolar depression, acute treatment and maintenance treatment. You will see them a lot because in this country we just just don't have the resources to monitor for lithium. Oh wait, no, we do. But remember that 15 billion. We have the resources for Tourette's. Again, aripiprazole, we use that as well. Acute agitation, according to the BAP-NAPICO algorithm you've seen, yeah, we can use second and third gen antipsychotics. Acute agitation, and again, for the other disorders, these are mainly add-ons, adjuncts. Okay, so unipolar depression, adjuncts, generalized anxiety disorder, adjunct, OCD, adjunct. Individual drugs with the specific indications, you can check them out in the cheat sheet, in the handouts, and later on in the table. Okay, so again, better to study them as unique drugs because each drug has a unique receptor binding profile, really. So you can't just say, all antipsychotics are used as adjuncts for OCD. No, only two of them are specific to that. Okay, so it depends. MOA, so based on neuroscience-based nomenclature, we call them, for second gen, D2 5-HT receptor antagonists. So those are the main receptors at play. And then for third gen, partial. So again, it's only third gen. That's the partial D2 receptor antagonism on top of the 5-HT receptor antagonism. So onset, so pretty similar when we talk about as mood stabilizers. That's about 1 to 2 weeks. Fastest is 1 week for some, but about 2 weeks for most. And then when we talk about positive symptoms, most will respond at 4 to 6 weeks. Some maybe as early as 2 weeks, you might see some initial improvement, but usually the bulk of it is 4 to 6 weeks. There you go. And similar to first gen antipsychotics, it's not just oral dosage forms. You might see depot injection, intramuscular injections, or disintegrating tablets, immediate release tablets. And you can divide the doses, like for risperidone, we divide the doses there. And for clozapine, some of them usually once daily. Since many of them are sedating, usually we give it at night. Or if it's divided, we give like a bulk of the dose at night. Now, again, similar to first gen, most of these we don't want to use in Parkinson's because in Parkinson's psychosis, yeah, it's possible. It's possible that in Parkinson's, your substantia nigra neurons, the D2 receptors there, along with the D2 receptors, they're all dying. But at the same time, you could have dysfunctional dopamine release in the mesolimbic pathway. So, different stuff going on with dopamine in different parts of the brain. You could have the worst of both worlds. So, Parkinson's disease psychosis is like the worst of both worlds. It's like the worst. So that's why most of the drugs won't work. Except for, we have two that are less risky, particularly clozapine, quetiapine. Clozapine, quetiapine, these are generally... Quetiapine's efficacy is kind of mixed, but it is used mainly because quetiapine dissociates really quickly from the D2 receptor relative to the other antipsychotics. So that's one. There you see a lot less ETS with quetiapine. And clozapine, at therapeutic doses, clozapine is the exception. It's really an enigma. Clozapine, I could do a whole session on just on clozapine. So I said earlier, you need the minimum 60% receptor blockade, D2 receptor blockade for antipsychotics to work. For clozapine, at the therapeutic dose, it blocks less than 60%. So it's an anomaly in that end, but it works. And it works so much better than other antipsychotics actually. So, what's up with that? Anyway, again, also mind the withdrawal. minor withdrawal symptoms,